طبعا اسمحوا لي الاول اشكر استاذتي الدكتوره حسنى يعني على دعوتها الكريمه ليا، ودكتور وليد رئيس المؤتمر على اللي هم يعني سمحوا لي ان انا اشترك معاكم النهارده. الجمعيه دي بيتنا التاني يعني، وفرصه ان انا اقابل اصدقاء اعزاء ما شفتهمش غير من سنين طويله، فانا سعيد جدا بوجودي معاكم. ان شاء الله تبقى مؤتمر ظريف لكل الناس يعني. النهارده احنا هنتكلم على ال FDG Positive Infective Endocarditis. الكاردياك PET-CT has different indications. طبعا evaluation of myocardial viability ومyocardial perfusion، وكمان evaluation of cardiac masses and the cardiac four eyes, infection, inflammation, infiltration and innervation. Regarding the cardiac four eyes, you have some indications that are used in clinical practice and some indications that are still under research. We have evaluation of prosthetic and native valve effective endocarditis, cardiac implant electronic device and left ventricular assistant device related infection, vascular graft infection, vasculitis, cardiac sarcoidosis. All these are indications used in clinical practice. And then we have some indications that are still under research, like cardiac amyloidosis evaluation, atherosclerosis and valvular disease, and myocardial innervation. Infective endocarditis is infection of cardiac valves and or endometrium. Its incidence is about 10 to every 100,000 general population. It has an overall mortality rate of about 30%. Who can develop, who can have infective endocarditis? Which patients are at risk of developing infective endocarditis? We have patients with congenital heart disease, whether they are unrepaired or repaired with prosthetic material. We have patients with prosthetic cardiac valve, implantable cardiac devices, indwelling vascular catheters, IV drug users, or patients with immunosuppression, or patients with Staphylococcus septicemia. All these patients are at risk of developing infective endocarditis. Clinically, we divide infective endocarditis into acutes and subacutes. The acute form, from its name, it's more virulent and more abrupt and severe clinical picture. It can occur in a normal valve and has poor prognosis, while the subacute has more insidious onsets and gradual progression. It usually occurs on abnormal valves and has good response to antibiotics. The clinical manifestations are usually general manifestations and non-specific and can be vague. Patient can develop fever, malaise, chills, night sweats, pain, joint pain, back pain. We can hear a murmur on the heart. We can find petechiae, and we have some more specific findings like osseous nodes and Janeway lesions and splinter hemorrhages. These are not very specific to infective endocarditis, but it can lead us to the diagnosis of infective endocarditis in suspected patients. These are the petechiae, can be seen in the mucosal surfaces of the skin or in the conjunctiva. These are osseous nodes and Janeway lesions. Osseous nodes are usually painful. Red occur on the fingers and toes. These are immune process, while Janeway lesions are painless, occur in the palm and soles and due to septic emboli. Clinically, we diagnose the infective endocarditis using Duke's criteria, and more recently the modified Duke's criteria. Duke's criteria have a major criteria for diagnosis and minor criteria for diagnosis. The major criteria are the positive blood culture, typical for infective endocarditis, positive echo findings, recent valvular regurgitation, and finally the positive FDG PET-CT. This FDG was introduced in the modified Duke Duke's criteria in 2023. The minor criteria, of course, are having a predisposing factor. The predisposing factors we just mentioned. We have fever more than 38 degrees, or we have any clinical signs like the immune phenomena or vascular phenomena. To diagnose it, to definitely diagnose infective endocarditis, we need 2 major and 1 minor criteria, or 1 major and 3 minor, or 5 minor criteria. This is definite infective endocarditis. Possible infective endocarditis needs 1 major and 1 minor, or 3 minor criteria. Rejected infective endocarditis, we can reject infective endocarditis if we have another diagnosis, alternative firm diagnosis of another cause for the patient's symptoms, or we have a lack of recurrence after less than 4 days of antibiotic treatments. Regarding imaging and infective endocarditis, the first line of imaging is transthoracic echo. Of course, it's easy, non-invasive, and available everywhere. But it has some disadvantages. It has low sensitivity for small vegetations, and of course, it's not very easy to use with the patient when the patient is obese or overweight. Second modality, the transesophageal echo. It has a very good sensitivity for vegetations. It can assess the valvular function, but it has low sensitivity in a patient with a prosthetic valve, because it will cause, of course, distortion of the image. And then we have CT. CT, of course, is non-invasive. It can detect the paravalvular complications that can occur, but it has less, it's not very sensitive for small vegetations. And of course, it has radiation exposure. What are the values of FDG PET-CT in suspected infective endocarditis? Of course, it will establish the diagnosis in cases of not established diagnosis. It can detect portal of entry, whether it can be cutaneous, dental, or any other portal of entry. It can detect disseminated disease. It's very important to detect in acute infective endocarditis. It can detect septic emboli anywhere. And of course, it can detect other causes for the patient's symptoms, including infective endocarditis. And some people say it has prognostic significance. Why FDG PET-CT is important in diagnosis of infective endocarditis? Because sometimes, many times, the diagnosis is not straightforward. As we have seen that we use modified Duke's criteria, and sometimes clinical manifestations are vague and non-specific, and there are also limitations of the blood culture, because we have from 14 to 34% of the patients will have negative blood culture, even though they have infective endocarditis, and we have seen that there are other imaging modalities have limitations. Review, several studies have been done showing the sensitivity and specificity of FDG PET-CT in infective endocarditis. This is a collective sensitivity and specificity. We can see that it is very good. It has very good sensitivity and specificity for prosthetic valve endocarditis, but it has a low sensitivity for native valve endocarditis. Meanwhile, it has a very good specificity in detection of infective endocarditis in native valve endocarditis. So it is a very good positive test in native valve endocarditis, but it's not a good negative test. It's a good negative in prosthetic valve endocarditis, but not in native valve endocarditis. Now we need to know when to do the study, how to do the study, and what to look for. When to do the study? After surgery. The European Association of Nuclear Medicine have suggested that we wait 3 months after surgery to reduce the incidence of false positive results. Other studies have said that we can do it after 1 month. So it's between 1 to 3 months is a suitable period after surgery. Meanwhile, a negative test in the recent post-operative period is a very good negative test. It can almost exclude the presence of infective endocarditis. But it is not a very good positive test because the more we are close to the time of operation, the more false positive results can occur. Also, some false positive results can occur due to some surgical procedures, some surgical adhesive, and some prosthetic valve types. This is a study that have been done to show the incidence or the activity of the FDG related to prosthetic valve after operation in patients without infective endocarditis. The first two lines are the 5 weeks after operation, then 3 months after operation, and then 1 year after operation. We can see that even after 1 year, we can still have diffuse uptake around the prosthetic valve. This is very important, and then we will see how to differentiate between normal uptake and abnormal uptake. Here we can see that all cases have uptake in the AC image, but few cases have uptake in the non-AC image. This is why evaluation of the non-AC image is very important in evaluation of suspected infective endocarditis. When to do study after antibiotics or during antibiotics treatment. Can we postpone antibiotics to do the study? The answer is no. We should not do this at all because this is a life-threatening condition. As soon as the physician suspects infective endocarditis, he can start antibiotics. All we can do is to do the study as soon as possible. Even if the patient is under antibiotics, we know that antibiotic treatment can lead to false negative results because it will reduce inflammation around the prosthesis, but we cannot postpone antibiotics. This is very important. This is an example of images for patients with infective endocarditis. A and C are patients without treatment, and B is a patient with infective endocarditis under antibiotics. You can see that, of course, the findings under antibiotics are not as striking as the findings in patients who are antibiotics naive. How to do the study? Patient preparation, we need some special preparation before doing a study. If we know that the patient is suspected for infective endocarditis, the aim, of course, is to decrease the normal cardiac uptake. We know that the myocardium prefers the free fatty acids than glucose in its metabolism, so we want to decrease the available glucose, so the myocardium will shift to fatty acid metabolism. We need the patient to fast more than usual. In normal FDG, we ask the patient to fast about 6 hours. Here we need the patient to fast 12 to 18 hours before the injection. And 24 hours before the study, we need the patient to have a high-fat, low-carbohydrate diet to increase the free fatty acids so the myocardium will shift to and take its metabolism from the fatty acids. And of course, avoid strenuous exercise for 24 hours. What about medications? We said, of course, that antibiotics we cannot stop, but we prefer not to give steroids before the study because it can lead to false negative. It will lead to decreased inflammation. If we are going to inject insulin, at least It should be at least 4 hours after, we should not inject FDG at least for 4 hours after subcutaneous injection of rapid-acting insulin or 6 hours after subcutaneous injection of short-acting insulin. Some studies have suggested that we should give heparin IV 15 to 30 minutes before FDG injection. This will lead to increase the release of fatty acid in the blood and will decrease myocardial uptake of glucose. This is controversial. Some people say that it should be done. It leads to proper image, and some people say it's not important and we do not have to do it. So it's controversial. These images tells you how good preparation will affect the image. The first one is normal, only 6 hours fasting. This is the second one is 6 hour fasting plus change in diets, and then 12-hour fasting and with diets, and the last one 6 hours and 24 change of diet and heparin injection. Injected doses, the usual injected dose for normal FDG PET-CT study, blood glucose should be less than 180. We image the patient from 60 to 90 minutes after injection of FDG. We need at least 5 minutes bed position for the heart to have a good quality image. Some people suggested that we can do dual time imaging to increase sensitivity, but again, this is controversial. Some people say it can lead to increase in sensitivity, and some other studies said it's not important and should not be used. What to look for? We have to read the study. We have a visual assessment and we have quantitative assessments. Visual assessments, we need to look to say it's positive for infective endocarditis. We need the uptake to be intense, to be focal, and to be heterogeneous. Either focal or diffuse heterogeneous. A diffuse uptake, a homogeneous uptake, is not consistent with infective endocarditis. And of course, the visual assessment should be done in both AC and non-AC images. This is very important because the prosthetic valve can lead to artifacts and can lead to false positive in the AC image. So we have to confirm that the uptake is present in the non-AC image. The quantitative assessment, we have different quantitative measurements. Of course, the SUV max and the best cutoff we have is more than 5.2. We have SUV ratio and we have valve uptake index. SUV ratio is a ratio between SUV max over the valve divided by SUV mean of the blood pool. SUV max over the valve divided by SUV mean of the blood pool. We usually measure the blood pool in the left ventricular cavity. More than 2.5 suggests infective endocarditis. Then we have valve uptake index. It is SUV max minus SUV mean divided by SUV max, all over the valve. SUV max, SUV mean, all over the valve, and a value more than 0.45 suggests infective endocarditis. This is a study published in 2022 comparing the sensitivity, specificity, and accuracy of different, whether visual or quantitative parameters. Here we can see that the visual assessment is even more important, more sensitive, more specific. And of course, the more we have, if we have a visual assessment positive and you have quantitative assessment positive, this means that the patient is probably have the infective endocarditis. I'll show you some images of the positive and negative cases. Here we have focal uptake, and here we have multifocal, diffuse heterogeneous multifocal uptake, and here we have diffuse uptake. So this is negative, and these are positive. Another case of a positive image for infective endocarditis. The uptake here is not diffuse around the valve, it's localized in one area, present in the AC and in the non-AC image. Another positive case, two positive cases, one for aortic valve, one for mitral valve, focal uptake, and here is multifocal heterogeneous uptake. Another case, AC positive, non-AC positive, and in the fused image it is seen localized over the valve. This is a case of a negative, and this is a positive case. We have seen this diffuse uptake before, and the study was negative with patients without infective endocarditis, and here we have uptake focal and localized uptake. So this is positive case for infective endocarditis. This is an example of infection related to cardiac device, whether infection related to the pockets, here, related to the pockets, or related to the leads, or of course here this is related to the valve. Infection related to leads, infection related to leads and pockets of cardiac device. This is a patient who came to us last week. This is one of our cases, complaining of fever of unknown origin. He was not referred as suspected for infective endocarditis. He was referred for fever of unknown origin. So as you can see, he was not properly prepared. There is a lot of cardiac uptake because he was fasting only for 6 hours. When he came to us, during history taking, we knew that he had an aortic valve replacement 2 years ago. And in the imaging, here we have focal areas of uptake related to the valve in the AC and non-AC images. SUV max was 8.7, SUV ratio was 3.3. So this patient has a very high suspicion of being infective endocarditis, and this is the cause of his fever. This is probably a subacute type because it was gradual onset and not very rapidly progressing. This is a study made to see the value of FDG PET-CT in evaluation of disseminated disease. Whole body PET detected distant embolization in almost 1/4 of the patients. And they say that the cerebral and the coronary emboli are usually symptomatic, while the other organ emboli are usually silent. Here is an example of how we will see the septic emboli uptake in the to dental uptake, and here liver and skin and soft tissue emboli, septic emboli, appear as foci of increased uptake. This is a multi-center trial to see the impact of FDG PET-CT on the management of patients with suspected infective endocarditis. They found emboli infection in almost half the patients, and management was modified in almost 1/4 of the patients after FDG PET-CT. Positive case with discitis and emboli in the muscle. There is a relation between infective endocarditis and discitis. In every patient we suspecting infective endocarditis, we have to look very carefully for the bones because sometimes infective endocarditis is associated with discitis. It can be the cause of discitis, and discitis can be the cause of infective endocarditis. Infection related to defibrillator with septic lung emboli, multiple areas of increased uptake in the lung. The other value of FDG PET-CT in suspected infective endocarditis is to detect other causes of patient symptoms. We can detect, of course, vasculitis. We can detect malignancy like lymphoma, like in this patient, or we can detect grafts infection related to vascular grafts. So all these are very important to exclude infective endocarditis and point the physician to another cause of the patient's manifestations. Prognostic significance of FDG PET-CT. This is a study published in 2019 saying that positive FDG PET-CT is predictive of major cardiac events in prosthetic valve endocarditis and new emboli events within the first year. And they say that more intense uptake is associated with worse outcome. Other studies have been performed and could not find any correlation between the FDG and prognosis. So it is not a definite correlation, not definite that the FDG will have a prognostic significance. Future perspectives regarding infective endocarditis imaging is using PET MRI, a native valve, because PET-CTs have a low sensitivity in native valve. We can use dynamic PET-CT to differentiate between infection and inflammation. We can use the help of AI to differentiate between infection and inflammation. Recently have been studies trying to suggest that there could be a value in guided therapy, when to stop antibiotics or when to change antibiotics. All these are still under research. Thank you.